Hi, so in this micro tutorial, I'd like to discuss how placental pathology could help gain an understanding of certain types of neurodevelopmental or neurological morbidity that could occur in fetuses and infants. And specifically what I'll be talking about here are neurological outcomes that relate to presumed insults in pregnancy or during labor and delivery that occur to a brain that was otherwise normally formed. So that the insult itself is an abnormality. What caused the insult etiologically in this sort of vague concept is something that went wrong in pregnancy or something that went wrong in labor, so that the maternal placental unit was insufficient and it caused some kind of an insult to the fetus or neonate. What I'd like to exclude then from the discussion are direct genetic specific neurodevelopmental anomalies, or direct specific metabolic anomalies, or even direct infectious etiologies where there's direct specific CNS infection, so where the agent crosses the placenta and goes specifically to the brain and causes specific brain damage. So what I want to then dwell on is more non-specific multifactorial outcomes where the supply to the baby is impaired. So far I haven't said when, and that results in injury to the brain that's often of a hypoxic but not truly or purely hypoxic etiology, but it's some insult that relates to something going on in pregnancy. So you could already see this is a field that's difficult to define, and I'm sort of doing this in a working way, and I'm doing this for the pathologist who wants to look at the placenta and aid in correlation. So let's start with the model, and then we could start defining terms more. So in a baby that experiences CNS injury, either in pregnancy or in labor, there's a complex sort of series of things that could potentially, play a role in that. So one of the things that we would first talk about are preconception risk factors. So what's the mother's health like to begin with? And those things could play major roles as risk factors in determining the neurological outcome of the baby. So for example, is there maternal disease? Is there maternal diabetes? That's a risk factor. Is there maternal thyroid disease? Etc. And in fact, there was a major shift, because underlying all of this is the whole concept of obstetrical risk. And so there was a time that there was a feeling, let's say in the late 70s and early 80s, and even towards the mid 80s, where people felt that if there was an adverse neurological outcome, it was usually intrapartum insult, that something went wrong in labor, and there was literally a feeling that, well, the obstetrician should have delivered the baby faster. And so because the baby asphyxiated during labor, and that's why the baby developed this neurological outcome. And some of the neurological outcomes that we're talking about here are things like cerebral palsy. And so that it was the feeling was that the obstetrician should have delivered the baby faster or done an earlier cesarean section, and that could have staved off the intrapartum injury. But then there was sort of a reversal in the literature, and what the literature then started to say was, hey, wait a minute. It didn't pinpoint, the literature that I'm now referring to did not pinpoint the time of injury to pregnancy as opposed to labor. What the literature showed is that a lot of babies who had neurological injuries such as cerebral palsy, there were preconceptional risk factors that had very little to do with the intrapartum or the period of labor and delivery. They were things that would have exerted their influence far earlier. So things like maternal diabetes, maternal thyroid, that would have affected the context of the pregnancy as a whole. And so there was this revelation in the literature that a lot of the injury occurs, or that a lot of the injury could start, or some of the factors could actually start in the antepartum era. And so there was this trend where people were thinking that all of the injury occurred antepartum, meaning in pregnancy but prior to labor, so prior to the time that you could do anything about it. And then with the advent of imaging, I'll tell you right now that there was a little bit of a shift backwards, and they realized no, some of the injury does probably happen during labor, but it's a complex story, and it probably occurs in a labor where the pregnancy itself was a high-risk pregnancy, and the pregnancy itself, already the baby suffered, and so the baby was preconditioned. And so it's very hard to sort it all out. And so I really want to stay away from the medical legal aspects. But I think, if anything, it's possible that the emphasis on trying to assign the ideological responsibility may have detracted and impaired our ability as a whole, as a profession, to fully understand and delve into the pathobiology. And so maybe an emphasis on timing the etiology may have countered an ability to really construe and a sophisticated proper model of the pathophysiology, which is maybe where we should most be at. So getting back to the model. So one of the things we know is that there are preconception risk factors that determine, that play a role, because everything here is playing a role. Nothing here is going to be solid. That play a role in sorting out some of the risk for fetal neurological injury are preconceptional risk factors. So even before conception, like the mother's medical state. Then the mother becomes pregnant, and then there are pregnancy-related factors within the pregnancy that also feed into the risk of neurological outcome. They don't tell you for sure if there will be or won't, but they account for some of the risk. And these are things in the pregnancy like IUGR, if the baby's small, if the baby's growth restricted, and they relate to things like placental insufficiency. And then even within the pregnancy, there are fetal risk factors for ultimate neurological outcome. And this includes things like if the family itself has a family history of not only other cerebral palsy or other neurological injury to the baby, but even family history of developmental delay, cognitive problems might play in to be risk factors for adverse neurological outcomes, the underlying genetic state. Then there's the antepartum era, so within the pregnancy but prior to labor, but as the baby's already developed and now we're getting into the pregnancy, you could get injurious episodes before labor. So for example, damage to the placenta, damage where the placenta starts to separate but doesn't separate entirely, things like that. Bad things could happen to the umbilical cord that exacerbate or that cause insufficiency in the antepartum era prior to labor. And these antepartum factors can not only injure the baby, but they could precondition the baby to respond differently to the anoxia, to the deprivation that naturally occurs during labor and delivery, such that the baby's response isn't what it would normally be because the baby's been preconditioned by the antepartum setting. And then labor and delivery occur, and during labor the uterus contracts, and labor is a time where there is going to be some natural deprivation where the maternal supply line to the baby through the placenta is naturally going to be cut off during labor, or at least not cut off, is going to be impaired during labor because of the contractions. And this is the intrapartum era. And so clearly some of the injury could occur during the intrapartum period. And some of these include things that we call sentinel events. And these would be things like either disruption to the fetal supply to the placenta or disruption to the maternal supply to the placenta, because as I said in previous tutorials, there's two supply lines, and so the mother supplies blood to the placenta, the baby supplies blood to the placenta, and they never meet, but they exchange. And so cut off of either the maternal or the fetal side could result in asphyxia. And so things that would cut off the fetal supply would be things like cord compression or cord accidents, and things that would cut off the maternal supply would be things like placental separation or placental abruption, and these could actually cause intrapartum asphyxia, or basically, malsupply, causing poor tissue oxygenation and acidosis during labor and delivery itself. And there are very well-written guidelines by groups like the ACOG, the American College of Obstetrics and Gynecology, to try to if you want to make a diagnosis that the injury occurred due to an intrapartum event, meaning something occurring during labor and delivery, the ACOG and other institutions have very good guidelines to try to substantiate that the asphyxia really occurred in the intrapartum setting as opposed to the antepartum setting. So for example, and I'll just give you one example, if the mother comes in with a nice reactive fetal heart rate and then experiences a deceleration, that would support an intrapartum event. If the mother comes in with a non-reactive fetal tachycardia, so you don't have this beat-to-beat variability, that suggests that something is already wrong. That suggests that the injury may have occurred at least partially in the antepartum setting. Let's go back to this context. If the mother comes in with good beat-to-beat variability, but then and a good fetal heart rate, but then experiences decelerations on fetal heart rate monitoring, and then if you look at the umbilical cord pH, and the pH shows an acidosis and a base excess, these features would also support an intrapartum event. So we try and sort out, and I'm not going to go into all the details here, where the hypoxic insult occurred, if it occurred in the antepartum setting or the intrapartum setting, and also imaging. Imaging could really help determine whether it's antepartum or intrapartum. And here is a role where the placental pathologist could have a role too, because sometimes the placenta shows you injuries that clearly occurred in the antepartum era. And the other thing that I would say now, while I'm talking about placental pathology, is we spoke about how factors in the pregnancy could influence how the baby reacts and how the placenta reacts during the intrapartum time. And so things like growth restriction, if you see features that the placenta already has a chronic insufficiency, that will influence how severe hypoxia could develop during the intrapartum period, and the pathologist could help look for features of chronic placental insufficiency. So I didn't give a complete notion here. Really what I wanted to show you is that there's a complex cascade beginning from the preconception era all the way to labor and delivery, where you have risk factors, you could have chronic placental insufficiency, you could have tying in of genetic factors, and then insults that could occur either prior to labor or during labor itself that could ultimately result in insufficient supply to the fetal brain, and that could result then in injury. And that there are criteria to try to help you understand or guess really, or know, it's not so much guess, try to help you suss out whether injury occurred more in the intrapartum setting or the antepartum setting. And I think it would be disingenuous for me to say that some of the emphasis on that distinction between antepartum and intrapartum doesn't have a bit of a medico-legal context to it. However, it also, part of the reason, and it's not purely medico-legal, in fact it's mainly not medico-legal, and the main reason why you want to know where the injury is because it defines treatment. Because if the injury occurs, if it's an acute asphyxial event, so for example, let's take the story, the mother comes in, she has decelerations, let's say there's pathological and clinical evidence of placental abruption, there's a low pH, so we know that the insult occurred during delivery. The MRI shows evolving injury that is least severe within the first 24 hours, and then gets worse for a while and then starts to get better, because it takes a while for neurological injury to evolve. So it suggests, the MRI evolution suggests an intrapartum injury. Then you could do things to react, to prevent, because the injury is ongoing then. The insult occurred at delivery, and then the neurons are dying immediately as the baby comes out, and there's things you could do. There's neuroprotective medication, you could try head cooling, there's various approaches. Whereas if it occurred 3 days ago in the antepartum setting, then maybe head cooling won't benefit. So the distinction is not at all mainly medico-legal, although there is a bit of a medico-legal, at least historical context to the emphasis on the distinction. The next thing that I just want to describe from you, so I know I'm jumping around a little bit, but like I said, it's up to the viewer ultimately to put the model together. I just want to give as much information as I can, is I want to define for you some main clinical terms. So the two main clinical terms that I want to define for you is, firstly, this term hypoxic ischemic encephalopathy, and then this term cerebral palsy. So hypoxic ischemic encephalopathy is a bit of an old term. And what this refers to is the neurology, the clinical neurology of the baby in the immediate postpartum setting. So the baby is born, is usually in the NICU, the neonatal intensive care unit, and if the baby has neurological injury, then the baby shows a pattern that they used to call hypoxic ischemic encephalopathy, and this could be graded. If the baby is almost lethargic and shows very little movement and no cry and no tone, that's more severe, a 3 or 4. And if the baby is just irritable and jittery, then that could be a 1. And we know, one of the things that seems to show out in the literature is that if the baby is going to have long-term outcome, a long-term poor neurological outcome related to antepartum or intrapartum asphyxia, the baby will usually show something immediately, like in the first few days, usually immediately after birth, and that used to be called, that constellation of features used to be called hypoxic ischemic encephalopathy. And it's quite well predictive, so that if the baby had a score of 1, the baby would usually do very well and have a good long-term prognosis, and if the baby had a score of 3, which means the baby was completely obtunded and quite lethargic and even seizures, and seizures themselves are well prognostic, the baby would have a high score, like a 3 in of hypoxic ischemic encephalopathy, and then would have a risk for a poor long-term neurological outcome. But hypoxic ischemic encephalopathy does not refer to long-term neurological outcome. It refers to the neurological status of the baby at the time of examination after birth. And we now, according to recent ACOG and other recommendations, we don't really use the term hypoxic ischemic encephalopathy because we don't always know for sure that it's hypoxic. There's other etiologies that could make a baby encephalopathic in the postnatal setting. And so now the term that's encouraged is neonatal encephalopathy, and that reflects the ambiguity of etiology. But the point is that this relates to the immediate afterbirth setting. And usually these are the kind of cases where the baby will have low APGARs, and then let's say APGARs, especially the 5-minute APGAR, which would be low. That's the important one, I think, the 1-minute and the 5-minute APGAR, and then the baby will show features more formally on a formal, sort of encephalopathy score that could be a 2 or a 3, and that could suggest a poor long-term neurological outcome. The second term is the term cerebral palsy, and that's really a lifelong condition, and it's a complex term, and there's several forms of it, and it's a sort of a clinical context, and it is in many ways the outcome of insult that occurs in the either antepartum or intrapartum setting with risk factors that could go way back further, but some insult, often with hypoxic type of contribution, but not necessarily purely hypoxic, occurs, and that sets up the baby for lifelong, neurological outcome, and some of it falls under the umbrella of cerebral palsy, and it usually involves, motor disability, and there's various terms, diplegia, quadriplegia. Cerebral palsy could be, subclassified on the basis of the motor and on the basis of motor dysfunction, and there could be plus or minus cognitive and autonomic dysfunction. It's a complex term, and it relates to the lifelong consequences of antepartum or intrapartum pathology. But one thing I want to emphasize is that not all babies with hypoxic ischemic encephalopathy go on to develop cerebral palsy, and furthermore, there are possibly some babies who develop cerebral palsy who don't have immediate hypoxic ischemic encephalopathy, but that last contention is not entirely clear to me from the literature, and I'm a placental pathologist, so I would have urge the listener to have, for that last point, can you have cerebral palsy without hypoxic ischemic encephalopathy? I would encourage you to speak to, greater experts. Okay, but at least we've defined the term neonatal encephalopathy. Let's not use the term hypoxic ischemic encephalopathy. Neonatal encephalopathy. We know that there's a grading system for that, and we've defined the term cerebral palsy, or at least weakly alluded to the definition of the term. Now, the other thing is that even given these various clinical constructs, there are different pathological constellations that could go into the various clinical constructs. So what I mean by that is, even an adult who has cerebral palsy, or a baby who, let's say, has severe neonatal encephalopathy, the pathology could be very, very different. So two babies both diagnosed with neonatal encephalopathy could have very, very, very different pathologies. And when we talk about neuropathology that's related to an antepartum or intrapartum event, or antepartum or intrapartum risk, there's two main groups there's like one main decision point that determines what kind of neuropathology you'll see. And that is, are we talking about a premature baby or a mature baby? In other words, and we could define it as 35 weeks or 37 weeks. So premature, let's define as previous to 35. Mature will define as greater than 37. And between the two, it could sort of be a little bit of both. So for the mature neurological injury, there's two main patterns that we see. And this really does often suggest, even though we don't use the word hypoxic ischemic, it often has a hypoxic ischemic, open quotes, feel, close quotes, a feel to it. And there's two main patterns of injury that we see in the mature, in other words, 37 weeks and on, gestational age at birth, two main neuropathologies that we see. And don't forget, I'm not a neuropathologist, so I'm just simplifying. One is this pattern that we call watershed area, like in the parasagittal cortex. So up in let's say, if this is like your frontal lobe or your parietal lobe, and this sort of parasagittal cortex here, which is a watershed between the anterior cerebral artery and the middle cerebral artery, and you see literally cortical damage. This is a form of cortical damage in this watershed area. And then you could see deep nuclear damage, like in the caudate, or I guess less the putamen, the caudate or the putamen, and I think less the globus pallidus, but you may want to verify that because I'm no neuropathologist at all, or the thalamus, and the thalamus is also a major part. In fact, it's often what you see, for example, in MRIs will be in the thalamus. And so there's two patterns again: watershed, which is more cortical, and deep nuclear, which is gray matter, but deep nuclear gray matter, not cortical. And there is some, and now we're getting very speculative, there is some speculation in the literature that watershed is more like a sort of a subacute, sustained hypotension, whereas the deep nuclear damage may be caused by sort of like a complete precipitous hypotension. So in watershed damage, the thought is that it's sort of like this sort of chronic sustained hypotension, so that the areas of least supply, the watershed cortex, gets damaged. And in that area, because it's slightly more subacute as opposed to truly acute, the baby will be able to redistribute preferentially to the brain, and so you will see features of body damage. So liver damage, elevated liver enzymes, etc., may be seen more with the watershed distribution. Where the deep nuclear is actually, for example, the insult may be for a shorter period of time, but it's complete. So there's perhaps less time to shunt blood preferentially to the brain, so you might not see as much liver damage, for example, other body damage in association with a deep nuclear context. But this still needs to be worked out. And of course, there's different vulnerabilities depending on the specific age at which it happened, but here we're talking about mature, so 37 to term. But there's two main patterns that you see on MRIs and even in neuropathology: watershed damage and deep nuclear damage, and that's in the mature infant, or in the mature fetus born at 37 weeks gestational age or later. In the premature fetus, the main neuropathological finding that correlates with neurological injury is this thing called periventricular leukomalacia, or PVL. And often associated with that is also deep nuclear injury, like thalamic or cortical injury. But in PVL, what you get, this is white matter. So this is different. We didn't see white matter damage very much in the mature. In the premature baby that develops poor neurological outcomes, you often see these white matter lesions. And in the old days, those white matter lesions would actually cystify, and they would become cystic. And that was this cystic periventricular leukomalacia, and you'd even get like cysts into white matter, and it got termed like porencephaly, etc., etc. And that reflects a sense that the premature oligodendrocytes are somehow metabolically vulnerable. And there was some thought that it may have to do with glutamate, and I think that's been, sort of relatively, disputed, relatively well disputed. And I think what there is good evidence is that the vulnerability of the white matter in the premature brain may have something to do with microglia in that region, and also metabolic immaturity of the oligodendrocytes. And whether glutamate storms have anything to do with it is contentious. I think the literature is sort of going away from that. But in terms of neurological injury of the premature baby that results in lifelong neurological morbidity, the main pathology would be periventricular leukomalacia, PVL. But we don't really see the same type of leukomalacia now in the era of good ICU care that we've really had in the last 10 years. So the neuropathology is shifting. We don't see cystic leukomalacia, and yet, and this is interesting, the neurological outcomes of the premature babies have not improved much. And so that's an interesting paradox. So I'm now just going to talk. I'm not really, you don't really need to look at the text for this part. So I'm going to say, why is it, and this was a very interesting mystery, why is it that even though we don't see cystic lesions in the white matter now the way we used to, the neurological outcomes aren't any better? And the answer for that came from some interesting MRI studies that showed that even in the context of periventricular leukomalacia, leuko-white, so periventricular damage to the periventricular white matter, the main thing that determines the neurological outcome in the baby is not so much how much white matter injury there is, but it was realized that those babies also have loss of volume and loss of complexity of their cortex. So there is a neuronal damage. Even though you don't see discrete neuronal areas that are destroyed in the cortex, there's a volume reduction in the cortex, excessive pruning of cortical neurons, and that really determines outcome. And even now it seems that we don't have the same progressive severity of the white matter lesions. There does seem to still be excessive loss of cortical neurons in premature babies that correlates with the white matter lesions, and that hasn't been as improved even in the era of excellent NICU care that we now have. We still haven't managed to solve the cortical attrition. And there is some evidence to suggest that the cortical attrition is not necessarily related to direct hypoxical apoptosis or necrosis of the cortical neurons at the time of labor and delivery. It's something that may be more evolving and progressive. The other pathology, and now back to the text, the other pathology that you see in premature babies is hemorrhages into the germinal matrix, periventricular hemorrhages. So hemorrhages, let's say if we think of this as if we think of these as the cerebral ventricles, you could get hemorrhages around them and the blood could inundate into the ventricles. But periventricular hemorrhage or intraventricular hemorrhage, which is definitely caused by premature. In fact, the more premature the baby, the softer, I'll just use that term, the softer the germinal matrix is, which is these developing neurons, the more likely the baby is to develop a hemorrhage, yet that doesn't seem to cause, in and of itself, long-term sequelae, except for hydrocephalus. It doesn't really seem to cause severe long-term neurodevelopmental delay unless it's associated with other things. So if you have hemorrhage in the context of PVL, that could feed in. So the real neuropathology of the premature that causes morbidity is PVL. Hemorrhages could cause pressure and hydrocephalus if they're very severe, but they don't seem to have a bad long-term. These are not so bad in the long-term, not bad in the long-term. This is much more worrisome in the long-term. So, the next thing I'd just like to briefly talk about is the placental correlates of these different forms of neurological injury. And of course, the placental correlates are going to be different so the placental correlates will tell you correlates of long-term or short-term hypoxia or asphyxia or other forms of injury, and therefore the placenta then could give you a window into what may have caused the neurological injury. And when you look at the placental correlates, of course they divide, once again, just like the neuropathology is different, whether it's a term or a preterm baby, so too the placental correlates of injury are slightly different whether we're dealing with a term or a preterm baby. And I'll elaborate on that in the next tutorial. I think I'll end this here. So I just want you to know, when you're the placental pathologist and you're looking at the placenta and you're trying to correlate it with, that the baby had, let's say, hypoxic damage, or baby had, let's say, neonatal encephalopathy. You get a call from the NICU and they tell you that please look at this baby's placenta. The baby is now experiencing neonatal encephalopathy. The potential placental correlates of that, and they're never diagnostic, they're just correlates, will differ. The strength of which correlates are more important will differ a lot by whether this is neonatal encephalopathy in a preterm baby or neonatal encephalopathy in a term baby. So, when the ICU doctor calls you and says to you, I'd like you to examine the placenta of a baby who has neonatal encephalopathy and look for potential correlates, your first question should be, what was the gestational age at birth? So that'll be the end of this installment. Thank you so much.